So firstly, we'll discuss the smaller topic, which is ataxia in children. As far as the NMC competency regarding this topic is concerned, we are supposed to broadly be able to discuss the etiopathogenesis, clinical features, and management of ataxia in children. The more finer competencies are to define ataxia, to enumerate all its causes, to describe the pathogenesis, to describe all the clinical features, to enumerate investigations, and describe the treatment for ataxia in children. So let us start with defining ataxia. Ataxia is defined as a disturbance in the fine control of posture and movement. It can also be referred to as an inability to perform a smooth, coordinated, and voluntary motor act. The importance here is the control in movement, the coordination, and the smoothness of movement. If that is lost, that is referred to as ataxia. So it becomes very important here to know what is not included as ataxia. So any gait instability which may be due to a motor weakness, maybe spasticity due to an upper motor neuron lesion or flaccidity due to a lower motor neuron lesion, such instabilities or inabilities to perform smooth movement due to motor weakness are not included in ataxia. Similarly, gait disturbances and repeated falls due to movement disorders. Movement disorders like bellismus, hemibellismus, chorea, if they lead to a gait disturbance, that is also not included in ataxia. So we need to understand what is the motor control and coordination that is done primarily by the cerebellum. The cerebellum receives sensory inputs from the eyes, from the vestibular system, and from the proprioceptive and somatosensory nerve fibers, the ascending tracts. And also a motor efference copy reaches the cerebellum. Through these inputs, the cerebellum then results in a motor control and a coordinated movement through fibers via thalamus, hippocampus, and the superior colliculus, finally leading to the primary motor cortex, the premotor areas, and the posterior parietal cortex. So any abnormality, any lesion, any defect in one of these would lead to ataxia. So if it is a cerebellar defect, we call it a cerebellar ataxia. If there is a defect in the frontal lobe or the posterior columns, we refer to it as sensory ataxia. If it is a defect in the vestibular system, we refer to it as vestibular ataxia. Similarly, if the visual inputs are gone, that leads to optic ataxia. Then ataxia may also be seen as a form of seizures, in which it is referred to as epileptic pseudo-ataxia. That is not true ataxia, that is pseudo-ataxia. And another modality or another thing that we need to know is functional or psychogenic ataxia. So functional or psychogenic ataxia can be identified or diagnosed by the fact that it is inconsistent and it decreases by if you are able to distract the patient into some other activity. Then on the basis of the onset and progression of the ataxia, it can be classified as acute ataxia or chronic, which is further classified as non-progressive or progressive, and intermittent or episodic. Our primary diagnostic approach towards ataxia is based on our history. The important things in history for ataxia particularly are the family history, a past medical history, or a toxin or a drug exposure history. Family history gives us a better idea about some inherited or some metabolic causes of ataxia. The past medical history is again important to identify some or to shortlist some causes of idea, and toxin or drug exposure, because ataxia is commonly seen as a toxicity for anti-epileptic drugs, primarily phenytoin. Then we need to follow this history by a robust examination, and then if required we would do further testing, which may include biochemical or some neuroimaging or some genetic testings. So on the basis of our history and examination, we would be able to identify whether the ataxia is acute or chronic, depending on the onset of symptoms. Then let us first take acute ataxia. Acute ataxia can further, on the basis of the history, be identified as whether it is post-traumatic or not. And also on the basis of the history and examination, we need to know whether there are some signs of raised intracranial pressure. If these are present, then we go ahead with a CT or an MRI, some neuroimaging. If the neuroimaging results in shows us a bleed, then we are sure that it is because of the hematoma. If the neuroimaging is normal but there is a history of trauma, we can assume that this is a post-concussion syndrome. If there is no history of trauma, no signs of raised ICT, then this is considered as an isolated acute ataxia, which would further require evaluation in the form of a toxicology screen and a lumbar puncture. The lumbar puncture would then be evaluated for cells, sugars, proteins, etc. So if in the toxicology screen we find high levels of the anti-epileptic drug or any drug, maybe phenytoin, so we would label that as acute ataxia due to intoxication. If in the lumbar puncture we have cells, then it can be viral cerebellitis or bacterial meningitis. And if there are no cells and there is no history of any drug toxicity, then we may classify that as post-infectious or para-infectious acute cerebellar ataxia. Now, on the basis of our history and examination, if we find that the ataxia is chronic, then we need to know whether it is persistent or whether it is intermittent. Intermittent would mean that there are some repeated episodes of ataxia, and in between the episodes the patient may be completely normal or not have ataxia. If there is intermittent chronic ataxia, we further go ahead by doing some EEGs, metabolic screenings, and then we can have a differential diagnosis of benign paroxysmal ataxia or a migraine or some metabolic disorders. If the chronic ataxia is persistent, then we need to identify whether it is progressive or non-progressive. Progressive would mean that the ataxia is gradually increasing with time. Here we would like to do an MRI, some metabolic screening, some molecular analysis, and common causes for this can be brain tumors, some metabolic disorders, and hereditary disorders like ataxia telangiectasia, Friedreich's ataxia, spinocerebellar ataxia, or ataxia with oculomotor apraxia. If the chronic ataxia is non-progressive, that is, the ataxia is not gradually increasing with time, Here we again would do neuroimaging. We may find neurological deficit, and the possible causes can be a stroke or cerebellar malformations like cerebellar aplasia, the Chiari malformation, the Dandy-Walker malformation, or the Joubert syndrome. Here, let us see some important causes of ataxia in children. The most common cause of acute ataxia is either acute post-infectious cerebellitis, which is also called as acute cerebellar ataxia, or is after a drug toxicity or a drug-induced ataxia, in which again most commonly phenytoin is the culprit. The most common cause for chronic ataxia, if it is very early onset occurring in children in the infancy, is ataxia telangiectasia. If it is late onset, usually occurring at 10 to 15 years of age, that is Friedreich's ataxia. Now here we also need to know some common treatable causes of ataxia. These are the metabolic syndromes or genetic syndromes which are treatable. Here vitamin B12 deficiency is important, vitamin E deficiency is important, and biotinidase deficiency is important. Because here if we correct or treat appropriately by giving supplements or diets, this ataxia is treatable. Now here are some pointers to diagnosis of common causes of acute ataxia. Say if you have the key features of acute cerebellar ataxia with a preceding viral prodrome, the most probable diagnosis is an acute cerebellar post-infectious ataxia. If there is an acute ataxia following drug overdose, which may be phenytoin, as we already discussed, that can be due to the drug toxicity. Acute ataxia associated with areflexia, hypotonia, and muscle weakness is something that is seen in Guillain-Barré syndrome. Acute ataxia along with areflexia and ophthalmoplegia is seen in what we call Miller-Fisher syndrome. And acute ataxia, if is associated with vomiting, nausea, and nystagmus, it goes towards labyrinthitis. So these are some common pointers that we need to include in our history and examination in order to be able to have a better differential diagnosis for ataxia. Let us discuss ataxia telangiectasia. This is a progressive ataxia which is early onset, seen in infants. It is associated with oculomotor apraxia, which is disruption of the smooth pursuit movements, and is associated with oculocutaneous telangiectasia, which is abnormally formed blood vessels seen most commonly in the eyes and also on the face. The natural course of the disease for ataxia telangiectasia is that usually in the early years it presents with chorioathetosis and dystonia, and then gradually truncal ataxia occurs. There are tremors are seen, dysarthria and dysphagia is seen, and usually the patient would end up with peripheral neuropathy by 10 years of age. The patient with ataxia and telangiectasia is usually bedridden by 12 years of age. What is very important here is that the cognition of the child is preserved even till the end. There is no deficit in cognition. The patient is also has a recurrent history of sinopulmonary infections and has a higher propensity for lymphoreticular malignancies. Next is Friedreich's ataxia. This is also a chronic progressive ataxia, but is late onset, seen in usually at 10 to 15 years of age. It has an autosomal recessive inheritance. It is characterized by gait ataxia, nystagmus, and slow saccadic movements of the eye. It may also be associated with involvement of the myocardium in the form of cardiomyopathy and the pancreas in the form of diabetes mellitus. Cranial nerves may also be involved. Pes cavus is associated with it. Scoliosis is associated with it. Characteristically, the deep tendon reflexes are absent and the plantar is extensor. In the MRI, it may usually be normal in the early stages, and occasionally in the later stages, we may find cervical cord atrophy. Now let us see some non-progressive cerebellar ataxias. These are chronic ataxias which are not progressing. The ataxia does not increase in my audio got disconnected. Yeah, but I believe I'm audible again now. Yeah, so the features, the characteristic clinical feature here. Sorry, it was just checking on my connection. Yeah, so it is characterized by hypotonia. What is important here is that only the tone is decreased, the power of the muscle groups is not decreased. So there is no weakness. There is hypotonia, no weakness, and normal reflexes. Also, these are usually associated with other delayed motor and language milestones. What is very interesting here is that even though the ataxia may improve with time, the associated cognitive and language problems, they persist. On an MRI or an imaging, we would usually find these to be usually normal or have cerebellar hypoplasia, or we may see the characteristic malformations. Let us discuss about sensory ataxia. This is usually lesser common than cerebellar ataxia in children, primarily because of the loss of sensory afferents, primarily proprioceptive. The common causes for this are hereditary sensory neuropathies, in which we characteristically see an abnormal nerve conduction velocity, and some posterior column dysfunctions, most common being folic acid and vitamin B12 deficiency. On examination here, there is either areflexia or hyporeflexia, and the characteristic Romberg's test is seen positive in sensory ataxia. Romberg's test, in which we would close the eyes and then the instability would increase. That is a positive Romberg test. Let us quickly discuss the treatment of ataxia. The most important part in the treatment of ataxia is occupational therapy and rehabilitation. And through this, we can help in the coordination training of the patient so that the patient is better able to balance and walk. Investigative or less commonly used treatments are transcranial magnetic stimulation and deep brain stimulation. We should also know some specific treatments for some specific causes of ataxia. If ataxia is associated with the oxyclonus myoclonus syndrome, we give immediate immune modulation therapy by giving prednisolone. And if there are some inherited metabolic causes, say A beta lipoproteinemia or vitamin E deficiency, we need to supplement vitamin E. In biotinidase deficiency, we give biotin supplements. In GLUT1 deficiency, we give frequent meals and a ketogenic diet. In maple syrup urine disease, there is a specific diet and thiamine. In Refsum's disease, the diet has to be phytanic acid free, that is free from all green leafy vegetables. And in urea cycle defects, there is again specific diets and sodium benzoate. So this quickly winds up our smaller topic, which was ataxia. And now we move on to our bigger topic for today, which is childhood headache. The competency for this, according to our NMC curriculum, is that we should be able to discuss the approach to and the management of a child with headache. This has been further divided into enumerating the causes, enumerating the types, describing the clinical features of the various types, enumerating all the investigations, and to be able to analyze the history and interpret examination findings in order to lead to a differential diagnosis for headaches. We should be able to discuss the approach to the management, and we should be able to describe the treatment of headaches in children. So, although it may sound very strange, but yes, this is the most common neurological symptom in children, and it has a very significant morbidity. Headache has been ranked as the second leading cause of years lived with disability worldwide. And childhood headaches have a higher risk or a propensity for developing chronicity and for persisting in adulthood, leading to a lot of physical and psychiatric morbidity. The estimated prevalence of headache in children is 58.4%. That is 58.4% children would have had a significant episode of headache, whatever may be the cause for that. It has been seen that headaches are more common in female children as compared to male children. Now, the most common type, that is migraine, most common type of primary headache, which is migraine, is seen in approximately 7.7% of children. At less than 14 years of age, the gender distribution for migraine is equal. However, in adolescents and young adults, migraine is seen more commonly in females than in males. This is the international classification of headache disorders, which has been given. This is the third edition of that classification. The common headache has been classified as migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headache disorders. So these first four are primary headaches, and then the others are secondary headaches. That is headache which may be attributed to either trauma or some vascular disorder, some substance abuse, some drug toxicity, some infection, disorders of homeostasis, any abnormality or difficulty or a lesion on the face, including the neck, the eyes, the ears. Then headache attributed to psychiatric disorders and some painful cranial neuropathies and other facial pains. And then the last classification is of secondary causes is other headache disorders. So this is the in total how headaches can be classified. The first four being primary headaches and the other being secondary headaches. We don't expect you to know all the entire classification, but yes, we expect you to know the common causes of primary and secondary headaches. So as far as the evaluation of a child with headache is concerned, again, very important is to have a detailed history. The detailed history, the easiest and the most difficult way is to get a headache diary. It is easy because if it is properly maintained, it gives us a lot of information. It is difficult. I'm sorry, I just got a message that my audio is gone again. Am I audible? Can you please, can someone please update? Great. Oh, great. I'm audible. Thank you so much. Thanks a lot. Thanks a lot, everyone. Okay, so it becomes difficult because at times the child may not be that descriptive, may not be able to describe it, and the parents might not be able to keep the diary. But if we have a headache diary, that is the best means for us to know about the headache. The diary usually has a detailed description of each episode. You would like to know the triggers, the duration of the headache, the severity of that headache, the effects that that headache has on the child, that is how severe it is, whether it is affecting the day-to-day activity of the child, any other comorbid features, and whether some medication was required and whether the child got relieved by that medication. So this detailed history has to be obtained by a headache diary. Then we need to assess the temporal pattern of the headache, and then we also need to do a thorough physical examination of the child. It is also very important here to note that all these things that we ask the patient to maintain in a headache diary are important in making the diagnosis. So these would be again important headings that you would like to include in your history. So the history that is obtained from both the child and the parent, we would again like to know the onset, the triggers, the progression of the headache, any characteristic feature of a typical episode, the disability that this headache causes, and the frequency of the episodes. For assessing the severity of the pain, we can also use some pain scoring systems. These help us to differentiate between mild and severe, and they also help us to monitor the response to therapy. In children more than 6 years of age, we can use what is called as the visual analog scale for pain. Now, after the history, we need to also assess the temporal pattern of the headache. The headache may either be like this green line, that is the symptoms, they suddenly rise over a very short period of time, and this is the first time it has occurred, so it is an acute headache. If there are repeated episodes of the headache, again they rise rapidly and then they improve, and in between the episodes there is no headache, there are no symptoms, so this is acute recurrent headache. Then the chronic headache, it may be chronic gradually, it may have an onset, and then the frequency and the intensity of the symptoms, they gradually increase. That is the red line. This is the chronic progressive headache. Then the mustard line is that the symptoms persist throughout, however intermittently their frequency or intensity may increase. So this is a chronic non-progressive headache. More or less the intensity is static. And then the last type is the new daily persistent headache, the mauve colored line, in which there is an acute onset of symptoms, and then these severe symptoms, they persist. So a new daily persistent headache. So let us see some pointers to the common causes of headaches. If it is acute, okay, so I have a window here which says that my network connection is slow, so I'm switching off my camera. Please let me know whenever you find that either my voice is not clear or the screen is not visible. Yes, so acute sudden onset headache in an otherwise healthy child could be due to some intercurrent viral infection. If there is acute sudden onset headache associated with some focal neurological signs, it may be due to an intracranial hemorrhage. If there is associated fever, it may be due to meningitis. I say here maybe because these are not the only causes, these would be common causes. Okay, so it is not it is not a clear-cut say dictum that if there is acute sudden onset and if there is focal neurological signs, it has to be intracranial hemorrhage. No, it is not like that, but a common cause for that would be intracranial hemorrhage. Okay, so if there is acute recurrent episodes, that is episodes or attacks which have symptom-free intervals in between them, the primary headache disorders can be, the common causes can be migraine and tension type. However, here we need to have important differentials in the form of complex partial seizures, cluster headache, and recurrent trauma. If the child has chronic progressive headache, that is a gradually increasing severity and frequency of the headache, it may be suggestive of an increasing intracranial pressure. Here we would need to examine and further evaluate the child. If there is chronic non-progressive headache or a chronic daily headache, that is, it is either frequent or near constant, this may be chronic migraine, or maybe in which we would usually see a normal neurological examination. Now, this is something again important that we expect you to know. These are the red flag signs. That is, signs which if we see or if we obtain in the history or the examination, we should be more thinking towards the possibility of a serious pathology. And if such red flag signs are present, we would have a lower threshold for neuroimaging or other investigations in these patients. So the important red flag signs are either there is short history, that is, it is either the first or the worst headache of the child's life. If the child describes it like that, there may be some serious pathology. Or if this is a recent onset, say within a few weeks, but there is severe headache which is recurring, or there may be an accelerated course associated with a change in character of the headache over a few weeks or days. Then there may be some signs of raised intracranial pressure. These signs can be early morning headache, early morning vomiting, the pain which may be disturbing enough to affect sleep, and pain which worsens with cough or the Valsalva maneuver. Then The red flag sign can be that there are some associations of the CNS in the form of personality changes, some focal neurological deficit or weakness, some visual disturbance, confusion, neurological deficits, seizures, or fever. These again, we would suspect that there is some CNS association, and we would like to go ahead with neuroimaging or some other investigation and think that this is not a primary headache but a secondary headache. Then there may be some history of neurocutaneous syndromes. There may be history of systemic illness, say malignancy with possible metastasis or hypercoagulopathy, and in children less than 3 years. If any of these criteria or the red flag signs are seen, we think more that the cause may be some secondary cause of headache. So even our physical examination for a child with headache primarily focuses on the secondary causes, because these are the things that we need to rule out, we need to identify and manage accordingly. So in our physical examination, we would like to do the blood pressure, we would like to measure the blood pressure, see whether the child has hypertension, because hypertension may be a chronic hypertension, may be a cause of long-standing headache, and the acute severe hypertension may lead to subarachnoid hemorrhage, and that can also cause headaches. We need to do the anthropometry properly. We need to assess for growth failure, which may be associated with chronic disorders and malignancies. We need to assess the head circumference, which if there is macrocephaly, the child may have some associated disorders which may be identified on the basis of that, say neurocutaneous disorders, say neurofibromatosis or hydrocephalus. Then we also need to see the head, the eye, the ear, the nose, the throat, the eye for uncorrected refractive errors, to assess for latent squint. These are also again very common causes of headache in children, especially in India. So then raised ICT, we need to see for papilledema, we need to see optic nerve pallor, we need to obtain a history and examine for acute otitis media, for any other sinus infection. We need to make the child open his mouth, see the teeth, see for any dental caries, any tonsillitis, and also we need to assess the temporomandibular joint, as temporomandibular disorders are also associated with headache in children. The examination, we continue, we see the neurocutaneous stigmas, they may be present, they may help us in identifying neurocutaneous syndromes. We need to assess the signs for meningeal irritation, the passive neck flexion, the Kernig sign, the Brudzinski sign, and we need to also assess for systemic signs of connective tissue disorders or vasculitis, which may again suggest the systemic cause for headache. After we have done all this, we may need investigations in the form of routine biochemical investigations, electroencephalograms, and neuroimagings. These are not routinely indicated for all patients, all children with headache, but if we identify some secondary cause, these may then be done to facilitate the diagnosis. Also, neuroimaging should surely be done if any red flag sign is present, as we discussed earlier. So now we come to the most common primary headache, which is migraine. It is the most frequent recurrent headache and occurs in approximately 28% of older teenage individuals. Again, more than 14 years, it is more commonly seen in females. It has a grave impact on the child and the family. The child loses school days, the parents lose their work days because they have to keep the children at home. Then the child may lose on social interactions, the child may lose on play, the child is unable to go for play. Say if the child has migraine, may affect 3 to 4 days every month, and that has significant repercussions on the child. So these are the common contributing factors or the triggers that are seen for migraine. More than 38 genes have been associated, the polymorphism has been associated with migraine. Also, there may be environmental stress, there may be metabolic triggers, diet, hormonal triggers, and some drugs which may exacerbate or lead to or trigger the episodes. What happens is that there is hypothalamic activation which leads to an alteration in the thalamocortical circuits, and these lead to altered brain activity and activation of the brain stem, which results in what is referred to as the cortical spreading depolarization. There is an initial wave of neuronal depolarization which gradually propagates in the cortex at 2 to 6 millimeters per minute. And this large wave of slow spreading depolarization in the gray matter leads to an inhibited cortical activity, leading to changes in, because of changes in the synaptic activity, the extracellular ion concentration, the blood flow, metabolism, and also the trigeminal system also undergoes some changes which lead to the headache and the associated aura if present. So the two major subtypes of migraine are migraine without aura and migraine with aura. Migraine without aura is also called as the common migraine or the hemicrania simplex. The migraine with aura is called as the classical migraine or the complicated migraine. Here, there are some transient focal neurological symptoms that usually precede or accompany the headache. Also included in this classification is something that is episodic syndromes associated with migraine. These are episodic syndromes that have characteristically been found to have some association or more commonly seen in patients with migraine. The cyclical vomiting syndrome, the abdominal migraine, the benign paroxysmal vertigo, and the benign paroxysmal torticollis. So migraine without aura is seen in 60 to 85% of the patients. It has a prodrome that is associated with mood changes, irritability, lethargy. Some children have an increase in yawning, some food cravings, or increased thirst. It is usually gradual in onset, and the pain is usually localized to the frontal and temporal region. It may be unilateral, it may be bilateral. So it is not very specific or a necessity in diagnosis that it has to be unilateral. Migraine can be bilateral also. So it is a pounding, pulsing, or a throbbing type of headache which has a moderate to severe intensity. That is, it interrupts the routine activities of the child. It may be associated with photo or phonophobia, and the child usually desires to seek a quiet and a dark place to rest and sleep, because the headache is relieved with sleep and increases with activity. The duration may range from a few hours to a few days, and children may have up to 6 to 8 times episodes every month. In developmentally challenged or pre-verbal children, the caregiver may give you a history that the child has repeated cycling events of quiet withdrawn behavior, which may be associated with pallor, regurgitation, vomiting, and a desire of the child to rest. So this is the diagnostic criteria of migraine without aura. What is important here is that the headache lasts 2 to 72 hours. It may have two of the four, that is unilaterality, pulsatile character, moderate to severe intensity, and aggravation by physical activity. So any two of these four should be present. The headache during the headache, at least one of the two should be there, either nausea or vomiting, or photophobia and phonophobia. And it is very important here that the headache should not be better accounted by any other international classification of headache disorders 3 diagnosis. So diagnosis of migraine with aura or without aura, both are diagnosis of exclusion. No other cause of headache should be able to better explain the headache. Now this is migraine with aura. Aura is usually seen in less than 20% of the children. It is very inconsistent. It occurs due to the cortical spreading depression, and the typical aura is a visual phenomena, but since there is spreading in the cortex, the aura may have a language, a motor, or a sensory characteristic. Migraine with aura, again, at least 2 attacks which would fulfill the following criteria, that is, one or more of the following fully reversible aura symptoms. The aura may be visual, sensory, speech, motor, brainstem, or retinal. What is important here is that it is fully reversible, and at least 2 of the 4, that is, aura should be spread. It should spread gradually over 5 minutes. The aura symptom should last 5 to 60 minutes, and at least one aura symptom should be unilateral, and the aura should be either accompanied or followed within 60 minutes by the headache. So we want 2 out of these 4. And again, no other cause should better explain this diagnosis. Next, we come to cyclical vomiting syndrome. It is recurrent episodic attacks of intense nausea and vomiting. At times, these are very predictable. The parents are able to tell that on this specific date, the symptoms may start. These are usually associated with pallor and lethargy in the child. And in between the symptoms, the child is perfectly normal. There is complete resolution. The next is abdominal migraine, which is again an idiopathic disorder seen mainly in children, which is associated with recurrent abdominal pain, moderate to severe in intensity, and midline in character. There may be some associated vasomotor symptoms or nausea or vomiting. The abdominal pain usually lasts 2 to 72 hours. And again, in between the episodes, the child is perfectly normal. And during the episode of abdominal migraine, there is no headache. We are studying this here because this is an episodic pain syndrome which has been associated with migraine. It is more commonly seen in patients with migraine. So this is benign paroxysmal vertigo, is also recurrent episodes of brief vertigo which occur without warning, resolve spontaneously, and the child is otherwise perfectly normal. Benign paroxysmal torticollis, again seen in infants and small children. The onset is usually in the first year of life. These are again recurrent episodes of the head tilting to one side with slight rotation, and again in between they remit spontaneously, and in between the episodes the child's neck head position, they're all normal. So as far as the treatment of migraine is concerned, pharmacological treatment, which may be either acute or preventive, the biobehavioral interventions which minimize the effects of the attack, and the education of patients and parents. This 3-pronged strategy is important for the management of migraine. The goals for the acute pharmacological treatment are consistent, to have a consistent response, to have minimal side effects, and to have the child be able to rapidly return to normal functioning. If we are able to identify the attack early, the pain may be suppressed or may be relieved by NSAIDs, particularly ibuprofen. However, if it is a more severe attack and our NSAID has not worked or helped us, The second line treatment is giving triptans, that is sumatriptan, zolmitriptan, or rizotriptan. This treatment by medications, the acute pharmacological management, may be given or useful if at home, if we give non-specific analgesics less than 2 to 3 times per week, or the migraine specific, the triptan drugs, less than 6 times in a month. However, if we have to give more doses or more treatment at home, then it is better that the child is taken to an emergency where dopamine antagonists or IV dihydroergotamine may be given. Preventive treatment is indicated only if there are more than 3 attacks in a month and these attacks are severe and long enough to hamper the activity of the child. The commonly used drugs here are propranolol, valproate, topiramate, riboflavin. But what is important here is that these preventive treatments, they don't start acting immediately. We need to give these medicines at least regularly for 2 months in order to be able to say whether the drug has been a success or a failure. The important biobehavioral interventions are, we can memorize it by the acronym SMART. That is, we need to have sleep. The child needs to have sleep which is regular and sufficient, meals which are regular and sufficient, especially including breakfast, and focusing more on the hydration. The child needs to have regular activity which may not be excessive. Aerobic exercise are preferred. Child needs to have some relaxation methods like stress reduction, stress management, and the most important, that is avoidance of known triggers, avoidance of stress, sleep deprivation, and any other identified trigger. The other common type of primary headaches is tension type headaches. These are also as common as migraine, but these are usually of mild to moderate intensity. The quality of the headache is dull or a pressure around the headache. It is not pulsatile. It is not associated with any nausea, vomiting, photophobia, or phonophobia. On examination, there is increased pericranial tenderness may be present. If you manually palpate the skull of the child, there may be some tenderness. Tension type headache is also self-limiting, usually relieved by paracetamol or NSAIDs and by behavioral interventions like relaxation training, biofeedback, and cognitive behavioral therapy. So to summarize our approach to a child with headache, we need to do a complete history and examination of the child. We need to screen for red flags. If red flags are present, we evaluate for secondary causes. If there are no red flags, we identify the primary headache syndrome. Now this can again be either episodic or chronic. Episodic, that is, if the frequency is less than 15 days per month, this is episodic, again maybe migraine or tension type depending on the characteristics of the headache. And chronic, that is if the frequency is more than 15 days a month, then the chronic, again depending on the type of the headache, may be chronic migraine or chronic tension type headache. Thank you. I am open for any questions that you may have. Please type your questions, if any, in the question box. It is 2:57. I still have time if anybody has any doubts. We have 2 to 3 minutes. Since there are no questions, I think I'll just wrap it up. Okay. Okay, sorry. I have some questions. Okay, symptoms of vestibulitis are very close to cerebellitis. Any pointers? Well, yes, pointers for vestibulitis would characteristically be vertigo and nausea, vomiting, and difficulties in balance. I agree. These are overlapping, but yes, nystagmus and vertigo would be more suggestive of vestibulitis. Well, migraine pathophysiology, yes, I can quickly go through that again. Yeah. As far as understanding the pathophysiology of migraine is concerned, firstly, we need to know that these are the triggers or risk factors, maybe genetic, environmental, metabolic, hormones, or drugs. In the presence of these risk factors, contributing factors, or triggers, there is hypothalamic activation. And this hypothalamic activation then leads to an alteration in the thalamocortical circuits. Okay, the connections from the hypothalamus to the cortex. And because of this abnormal or altered brain connectivity, it leads to activation of the brainstem or some other cortical region. And once this one region is activated, there is what we call as the cortical spreading depolarization. That is, this neuronal depolarization gradually spreads 2 to 6 millimeters per minute in the gray matter. As a result of this inhibited cortical activity, there are changes in the synaptic activity, changes in the extracellular ion concentration, changes in the blood flow in the brain, changes in the metabolism in the brain, and changes in the trigeminal vascular system. And it is because of all of these changes which are manifest as headache and aura. I don't want to complicate it to the metabolic level, but this much basic understanding is good enough for us to explain as to why there is an aura and a headache in migraine. Okay, thank you. Since there are no other questions, I'll just wrap up the class. Thank you so much, everyone. It was a pleasure. Thank you.